Bismillahirrahmanirrahim. Assalamu alaikum and good morning, ladies and gentlemen. I welcome you all to the 13th Hands-on Colonoscopy training course. Before we start formally, I would like to welcome our international faculty for the course. It's always a great pleasure to have Dr. Waqar Ahmed and Paul Hagan with us. Thank you very much for traveling all the way from UK and taking out time for this course. Now I would tell you briefly about our courses here. This unit was established in, rather not established actually, the endoscopy suite was established near about more than 10 years back. And this unit, surgical unit 4 at Civil Hospital, is quite unique. And it's quite different from other units of the government sector and private sector hospitals, be it from providing advanced laparoscopic or robotic surgeries to the patients, poor patients of this province, to its state-of-art endoscopy unit. And it's one of the best endoscopy units, I would say, in the country now. We have had ourselves recognized for this. Through our work. We were very lucky when Dr. Saad Khalid Niaz joined this unit as the director of our endoscopy. And he's someone who doesn't need any recognition. His services were recognized by the president as well when he was given Tamgha Imtiaz for his services. And ever since he's joined this unit, we have had lots of improvements in the sense that this, it all started actually with teaching and training. And these workshops are just an extension of that teaching and training. Initially, I think it was only Dr. Saad Niaz who used to do ERCPs, but when he joined this unit, he trained his team. Despite the fact that we are all surgeons here, but we are like 3 of us, rather 4 of us surgeons were trained by him to do all the advanced endoscopic procedures. So that is, I think, when he decided that, yes, if he can train the surgeons, he can train the gastroenterologists as well to do endoscopies and advanced. And this is when we started our courses. And this unit was unique in the sense that we were the first ones to start these hands-on training courses in Pakistan. And ever since, there have been lots of units who have started doing these procedures. I still remember that the first course that we conducted, we had lots of applicants for the course. And it's amazing to see that now with all the other units all over the country who are doing these courses, still we have increasing number of applicants every year. And this is all because of the standard of this course and the amazing and exceedingly talented faculty that we have for these courses. Now I would like to request Dr. Saad Khalid Niaz to please come and say a few words.
Bismillahirrahmanirrahim. Thank you very much, Sajda, for that kind introduction. Welcome, Waqar and Paul. We had a slight gap in our colonoscopy course. Normally, we have 2 courses a year. So we try and do 2 colonoscopy courses a year. I think this is the first year we did 1. This is the first one. Sajda rightly said, we take pride in the fact that this course, the way we do it here, is not done anywhere else in Pakistan. I've been to all courses and all units, and correct me if anyone disagrees with me, but I don't think hands-on course, the way we do it, is done anywhere in the country. In fact, I would not be wrong in saying that outside UK, we are probably the only center in the world that's doing these kind of courses. And we do colonoscopy, ERCP, and EUS courses. So why are we here? Now, we are here because we want to share with you what we have learned over the last 25 to 30 years. Okay. Some of the things that took us a lot of time, we want to share so that you know it almost at the very early start of your career. Why are you here? You have to understand that you are here because you are accepting that you've come for a basic hands-on course. So if you're already an expert, you can do everything and you know how to do it, then you're at the wrong place. So let's start by accepting this very important fact that you're here to learn the basics. Now, some of those you already know because you must have been doing or you are doing cases, but some will need to change. And that is what the advantage of attending such a course is. So that your foundation is right, and then you can build and become or go as far as you want to. So we are not here to really, in 3 days, make you an excellent colonoscopist and throw you back to your unit. We are here to give you or correct certain basic fundamentals of doing the procedure, make you understand them better, and hope that, in future, you will be able to then build on that, okay? So some of the things that you might be doing would be different. Now, there are always more than one way of doing things. Waqar might have his own way of doing something, and you may have another way because your, teacher, your trainer may have another way of doing things. So you can assess and see, and then later on in your life you can decide, well, I prefer this way or that way, because there's always more than one way of doing the same thing. Similarly, Paul may have slightly different way, and maybe I'll have slightly different way. But overall, the idea is to reach or achieve the objective of doing an endoscopic procedure, and in this case, it's colonoscopy. So what we do here is generally in the first couple of hours, we will be discussing just generally some of the aspects of colonoscopy. And then we will have a mannequin here, a dummy, where we'll try and make you understand some of the concepts. And then eventually we'll take you there. We try and give you each four colonoscopies. Try and rotate through different faculties. And we always share with each other where we think you are and where you need reinforcement. And you can always come and tell us where you are having difficulty. And I'll ask you that in a minute anyway. So first thing what I wanted to do was quickly introduce Waqar. We go back long way. When I used to be long time ago, when I used to be in the UK. Waqar is one of the pillars here in these courses, because he and we had this dream to start this course, and then he found Paul, and then everything fell in place, and we are here. Waqar is a very eminent and well-accomplished endoscopist and a gastroenterologist working in Manchester. And he's like a brother and has done great service for our unit, and I'm sure for the country. Paul is more of a Pakistani than British for sure. He is Irish. No, he's Irish, but he's more of a Pakistani than British. Okay. Paul, what's your number now? 65, 60, 70? 77,000 colonoscopies. So that's, if I take 3 births, maybe 4 births, I may be able to do that. So in my lifetime, that's not happening. And I don't think many people in the world can claim that. Maybe he's the only one. One of the best teachers. He's very passionate about teaching, much more than I am, and has a lot of patience as well. If you don't understand him, sometimes the accent is, and he would joke with you. So if you don't understand anything, please ask him. Sorry, didn't understand what you said. He doesn't mind, do you? Good, thank you. I will also welcome Janet, Paul's better half, who runs a neurosurgical pediatric unit in one of the very big centers in UK, in Nottingham. And she allows Paul to come here, and we don't allow Paul to come here without her. Okay, so that's our introduction. Sajda Qureshi is a professor here, Professor Shahryar. You will be meeting them, the other team, while we are doing this. And what I want to do now is quickly introduce the hands-on people, please. So okay, I'll tell you what you need to tell me. Where you're from, okay, how many colonoscopies have you done? How many times are you reaching cecum in your last 10 to 50 colonoscopies, if you're reaching? Terminal ileal intubation, sedation, what do you use? And what are your difficulties that you feel are your difficulties in colonoscopy? Okay?
Assalamu alaikum. I'm Dr. Saira Mohammad Ali from Patel Hospital, Karachi. I'm year 3 resident of gastroenterology. I've been doing training under Dr. Sadniaz, alhamdulillah, and so far I've done around 250 colonoscopies. As far as the last 50 colonoscopies are concerned, the cecal intubation rate is about 90%. About difficulties which I feel is obviously reducing the loop sometimes gets difficult, and more of the scope outside the patient, it gets loopy. That's thing which I feel very difficult and looks a little technical difficulty. Anyway, about the sedation, we usually start the procedure with 2 milligram of dormicum, and then depends on the patient's comfort level. We try to ease the patient, we try to talk to the patient initially as well. We comfort the patient, we talk to the patient, we explain them the details, what are we going to do with the patient, and so basically the patient is in loop with us, they stay comfortable with us, and so on. Thank you.
Thank you. My name is Dr. Muhammad Aslam, and I am Senior Registrar Gastroenterology, PKLI, Lahore. I have done about 530 colonoscopies.
530?
Yeah, 530. And my cecal intubation is about 85 to 90%, and terminal ileum intubation is about 80, 75 to 80, probably. My difficulty is that sometimes I cannot resolve the loop. When I cross the hepatic flexure, usually my scope is very loopy, and I try to manage it, but sometimes it happens that it is difficult to go without loop. Otherwise, I think the sedation is minimum sedation I use. Mostly, I don't give sedation to the patient because in our center there's no backup support. So minimum sedation and sometimes loop recognition issue. Otherwise, it's okay.
When you say you don't have backup, what do you mean?
I mean, because my hospital is is under construction, and there is no ICU, proper ICU and indoor facility. So we don't have much thing in the backup.
Okay.
I am Dr. Ali Rashid from Surgical Unit 5 Civil Hospital, Karachi, and final year resident under Dr. Sajda Qureshi. I have done approximately 150 colonoscopies, and my cecal intubation rate is around 80%, and terminal ileal intubation is around 40 to 50%, which is actually very low. And my difficulties are one thing I think the terminal ileal intubation rate, which is I found difficulty with it, and also sometimes I found difficulty in formation of loop in the left colon.
Okay.
I am Dr. Jawad Khan. I am from Peshawar, and I am working as assistant professor in Peshawar Medical College. My cecal and terminal ileal intubation rate is about like 80%, and I have done about 200 to 250 colonoscopy till now. The difficulty I face is all of the candidates mentioned, like sometimes it becomes very difficult to de-loop the colon and shorten the colon, and sometimes to maintain the proper access of the colon, especially in the hepatic and cecal.
I'm Dr. Wahid from Deer Lower KPK. I joined as a district specialist gastroenterology hepatology and September 2018. I was the one to start my gastroenterology unit over there. Since September 2018, I did more than 130 colonoscopy. The seeker rate is mashallah good. It is 80 to 85%. Ileal intubation is around about 75%. And the most difficulty I feel is in the distal colon to de-loop or short the scope and to pass the bends and splenic flexure. Thank you.
What about your sedation?
Actually, I'm not using it to be on the
No
safe side.
sedation at all?
No, because
What about you? You don't use sedation?
Midazolam.
How much midazolam do you use?
3 cc.
3 midazolam.
About 3 cc.
Okay. We have observers here as well?
Yeah.
We have. Okay.
There's one lady
Oh
who
my
just
God.
came today in the morning, and so we have just included her with her. She's come from.
Okay, I am
Lots
Dr.
of-
Mariam Vakar from Medical Unit 3, Ward 7, JPMC, and I have come as an observer.
Okay. Mariam, you were from Zishan's and Dr. Masroor's unit?
Yes,
Yeah,
yes,
okay.
sir.
Okay, for observers, before I ask you to introduce yourself, you have to understand there's no hands-on experience for observers, okay? Because that's one complaint we get. I wish, we wish there was some experience. The problem is that our focus is the
Hopefully
hands-on
next
people.
time get
So
a chance.
now that you've done an observer's course, if you're good to Sajda, she is the boss here. She does, she allows whoever. Honestly, I have nothing to do with it. Sajda, you vouch for that, okay? Occasionally, I'll tell her, please consider this one. I think she's written to me a few times. You've come from JPMC. Are you doing colonoscopies?
Sir, I've been doing upper GI endoscopy
not-
independently. I attempted, I'm in the learning process.
Okay.
And most of the time I have observed. And I have started it, but I could not get across. I just could, cross the sigmoid, then I could not get beyond it.
Good. I like your honesty.
Assalamu alaikum. My name is Dr. Aisha Siddiqa Hashmi. I'm a general surgery resident in Surgical Unit 4, Civil Hospital here. Any other thing? Usually, we are allowed to do sigmoidoscopies and some colonoscopy under direct supervision of our seniors. I have reached cecum quite a lot of times, alhamdulillah, but mainly I get stuck at the hepatic flexure, and most of the time I feel like it's due to loop or something, but and I've never intubated terminal ileum, so I don't know.
This time we have 5 observers from surgery. They are about to finish their residency, so they were really interested in attending the course before they go away.
Well, these two have already, I can see faces here who've organized colonoscopy courses before. Okay, Ali?
Assalamu alaikum. My name is Dr. Ali Adar. I am currently working in Surgical Unit 4 under Professor Shahya Gazamfar. Yes, we have done upper and lower GI endoscopies, both sigmoidoscopy and colonoscopies, and reached up to the cecum quite a few times, and just 1 to 2 times in terminal ileum under Professor Shahya Gazamfar supervision. So, yes, and we are using obviously midazolam.
I don't want to, okay.
Assalamu alaikum. I am Asma Amin. I am doing residency here in S4. I did a lot of colonoscopies, but always I have a difficulty in crossing hepatic flexure. But these all colonoscopies are under the supervision of Dr. Aftab or anywhere who is posted in colonoscopy. That's it.
Okay.
Okay, my name is Dr. Sana. I am a final resident under Professor Sajda Qureshi in Surgical Unit 5. I have done endoscopies, but I have never done a colonoscopy yet. So for that, I haven't attended the course.
Assalamu alaikum. I'm Dr. Sumayya Khan. I'm general surgery resident at Surgical Unit 5. I've not done colonoscopy or sigmoidoscopy independently, but I've been assistant in them and observed them. So I'm basically here to learn colonoscopy and sigmoidoscopy.
Assalamu alaikum. I'm Dr. Shafaq from Holy Family Hospital, Rawalpindi, and I'm final year trainee in gastroenterology. I have done around about 50 colonoscopies.
You're with Professor Umar?
Yes, sir.
Okay.
And sir, I have done around about 50, but the problem I am facing around like hepatic flexure, crossing that and de-looping and obviously terminal ileum. I haven't, once or twice I have intubated terminal ileum. I feel difficulty in terminal ileum intubation. Cecum intubation rate is 80%. So,
Good. So you've done 50 and you're 80% already?
yes.
That's wonderful.
And we don't go for sedation.
You don't use sedation there at all?
No, sir.
Okay. Great.
Assalamu alaikum. My name is Dr. Mohsin. I am from Hyderabad and I am R3 resident of gastroenterology.
You're with Sadiq Mehman?
Yes, sir, Dr. Sadiq Mehman. And I have done about 200 of colonoscopies and 90% about cecal intubation.
Good. So, great. So we have a pretty experienced group this time, which is going to make our task very easy because it'll be interesting to see how you guys proceed. One thing that comes out very strongly is about loop, and we'll be focusing on that. There'll be some basic training on loops. What are loops? How do you reduce them? Etc. And if you don't have loops, then hepatic flexure really going into cecum shouldn't be a problem. It's only when you have a loop really you have a problem. Otherwise, hepatic flexure, once you've gone there, I've heard a lot of people say that. Okay, so there is a card that you should have. So as I said, what we will do is a lot of things we'll discuss. We used to have formal lectures before, but because, and I think, with you people already done 200, 150, 100 colonoscopies and all R3s, and so I think what we would do is we just encourage some discussion about certain aspects of colonoscopy. We'll ask how they do it, so and also some of the things about indications, contraindications, etc. So once we've done that, we will show you a colonoscopy done by one of the faculty, just to show you how it's done. And then we will, as I said, we'll be working on the mannequin. And once we're done with that, we'll then start the hands-on colonoscopy, where one person will go with one faculty. Okay, you will be doing, and the faculty will be telling you. When the faculty tells you to stop, it means you stop, you freeze. There is a reason why they're stopping you. If they're not feeling comfortable for you to proceed because of any risk to the patient, they'll tell you, please hand over the scope, okay? Or, you need to stop and give the scope. Don't feel offended by that. It's mostly patient safety that they would be doing. Most of the time in colonoscopy, we don't do that. We try and make you try and explain to you how to pass the difficulty that you're stuck at. But sometimes we take over, we pass that difficulty, we show it to you, and then hand it over back to you. A few things that are, so this will continue from this afternoon till we finish, as I said, 4 cases for each of you. Sometimes we are lucky we can give you the 5th one as well, but our aim is to give you 4 cases. By the end of the thing, during the session, what will happen is one of the colonoscopy will be transmitted here for the observers and those who are not in the room, the 3 candidates who are not going to be in the room. And one of the faculty one of us is always always here to explain to you. During that, we do a lot of micro teaching about issues related to colonoscopy. Obviously, the most important thing is about indication, okay? And then also to know when you're not supposed to do a colonoscopy, which is contraindication. And then how do you prepare the patient? So all these things we'll cover during the course. Okay. Bakar, if I may start with you. in your practice, what would be, what is your standard list like? In a list, let's say you start at 9 o'clock and you finish at 1 o'clock, how many cases do you do and how much time do you allocate to a colonoscopy?
Normally, the standard service list is made up of 12 units. That can vary in case there are any emergencies, but as a standard, we do a 12-unit list. One gastroscopy is 1 unit, and colonoscopy is 2 units. If we carry out any therapeutic procedure, then you add on units. Like if it's a simple polypectomy, we just do that in 2 units. But if it's a EMR, then you add on a couple of units to that. If it's a complex EMR or ESD, then you add more units to it. But a standard the list which we normally do is 12 units. If it's a training list, then we do 8 units in that, or less.
8 units.
8 units in a training list.
So that means 4 colons in a list.
Yeah, that's our 3 colon, couple of flexigis.
3 colons, couple of flexes.
Yeah, but it's 8
So
units.
training list gets more time.
It's more time.
Would
yes.
that be the same with you, Paul?
We do again. We call it point. We call it points, not units. Each point is 15 minutes. For the average endoscopist in my unit, it's 12 points in the morning, 10 in the afternoon, and 9 in the evening, and that's your total for the day. Interestingly, as Vakar alludes, depending who you are, you'll do that 3 list in the morning. I'll do that probably in the morning. Vakar would probably do similar if needed in the morning, depending on who you are. It gets frowned upon. And also because of litigation, there is a court case going on at the moment about somebody who has overbooked their list by 1 point and they've had a complication. And the lawyer has found out how many points was on the list, standard for the UK, and they've decided to take it to the court and say, how did you not put yourself under pressure by time? So the UK is governed by a lot of... It's becoming silly with regards to law.
And I assume both of you in your units, they now monitor the number of times you reach the cecum, the number of time you do
that
whatever.
To me is getting is stupid, because if you actually sit down and look, for someone like us three, not being disrespectful to anybody, if I didn't reach the cecum, I've not reached the cecum for a reason in 98% of the time. If I say it's bad prep, I then don't have to be expected to press on to the cecum, to say I got to the cecum, to say this is an unrecordable procedure. I hate it, but because of the way the data is run in the UK, you have to actually feel a pressure on you to actually complete a test that has got no outcome measure whatsoever.
Okay. But generally, the procedures are now monitored in the sense that somebody is actually...
So the procedures are monitored locally, so everything is recorded locally. The only robust data is the data you collect yourself. The data that's collected on any data system, apart from yours actually seems very robust because it's on an Excel, but it's a local system. But any systems these days are really dubious in how they interpret data. So there's 7 national endoscopy reporting tools that is widely used in 85% of the hospitals. There are still 15% local reporting tools. Yours is a local reporting tool, but very robust. And I really like yours, but it wouldn't run in a hospital because it's got an Excel at the back of it, and also the way it records the data would be great for our unit, but it'd be heavy on memory. The issue that we've got also is that it reports it and it uploads it automatically nationally, and it goes to 2 systems. One is JETS, and now we've got the National Endoscopy Database. If you've read about in the UK about NED, National Endoscopy Database, it's useless. It's not fit for purpose. It's rubbish. So what we've got now is NED2 that's coming in. That's actually better. So if you believe NED, and I've checked before I come, and I'm sorry to embarrass you, but both he and I have got a cecal intubation rate according to NED in the 2nd trimester of 72% and 74%. However, when you actually look at NED2 data and go over the same period, we've both got 97% plus. So NED1 has got a lot of issues in it. So databases are only good as how they can interpretate and interrogate the data and what you set your data stream up for.
Okay. Coming to indications, one of the things that I'll start with something difficult. Obviously, everybody knows here, my threshold for anybody having a colonoscopy with blood and stool, whether it's one drop at whatever age, and I mean literally a drop, I suggest minimum sigmoidoscopy or colonoscopy, whatever they prefer. But I would not let somebody go out of my clinic, at least advice-wise, that they should have a procedure done. I don't believe hemorrhoids occurs unless I've ruled out. I've checked up to sigmoid, then hemorrhoids, yes. But otherwise, I don't believe it. Okay. In Pakistan, slightly different. We are getting younger patients who are, in the last month, I've diagnosed 3 doctors. Okay. One being treated as anal fissure by a surgeon, found out to have rectal tumor. The other, metastatic rectal tumor. Young doctors, they're not very old. So, and the third one again, a slightly more proximal tumor. So, for me, my threshold has changed. Anybody at any age in Pakistan with blood and stool, that's what I do. You can question, but that's the experience I have. So, blood and stool in Pakistan for me is an indication for minimum sigmoidoscopy. When I say sigmoidoscopy, I don't believe in rigid sigmoidoscopy. I think flexible sigmoidoscopy is the way forward. Rigid sigmoidoscopy is very, very operator dependent and very limited view. So I don't know why, what is the use, but anyway. The issue that I have, Waqar, is with ulcerative colitis. What are the indications of colonoscopy in a patient with ulcerative colitis, diagnosed ulcerative colitis in your practice?
To diagnose ulcerative colitis, all you need to do is a sigmoidoscopy, whether it's rigid or flexible, because in ulcerative colitis, as you all know, the rectum is involved in 100% of the cases, unless the patient has been getting local treatment with steroid or 5-SA enemas, in which case the rectum might be healed, rectal mucosa might look healed and may look normal. However, as Dr. Saad Niaz said, how often do you need one? Well, initially, if you've diagnosed it with flexible sigmoidoscopy, you probably need a colonoscopy at some stage to determine the extent of the disease. And that can be only when the active colitis has settled. You don't do a full colonoscopy when the patient has got a fulminant colitis, because you can cause complications like a perforation or a toxic dilatation. So that's the first index colonoscopy you need to determine the extent of the disease. During the course of the illness, if the patient becomes symptomatic, then you probably might need to do a further colonoscopy, or most of the time I do a flexible sigmoidoscopy to see if he's had a flare-up. That's all. Unless you want to decide on changing the type of treatment the patient is getting, because if we are going to consider biologics, which is like infliximab or adalimumab, then you would consider doing a full colonoscopy for documentation purposes, or even a flexible sigmoidoscopy might suffice. Otherwise, there is no indication to do colonoscopies left, right, and center in these patients. You start doing colonoscopy for surveillance purposes after they've had disease for over 10 years. And in that case, the first 10 years, you do colonoscopy every 3 years. In the second decade of the disease, after 20 years of disease, you do it once a year or every 2 years. Some people do it every year, but some people. If the patient has got primary sclerosing cholangitis, then after 10 years, you do a colonoscopy every year, because the risk of colorectal cancer is higher in these patients.
So, please, that's what I was going to say. Please, this is a very informal course. I forgot to say that in the beginning. We have professors here, but the professors are not in a professor mode today. So, okay, so we want to keep it very relaxed. We want you to interact and ask questions. And if you don't agree with something, just stand up and say you don't agree.
So my question is that was index colonoscopy, and you start giving treatment to the stomatitis patient. After how much
is well, I don't need to do a colonoscopy to determine if he's well. If his clinical, if his bowels are opening once or twice a day, the stools are of normal consistency, there is no blood in his stool, he's not getting any abdominal pain, he's not getting constitutional symptoms, and we normally do inflammatory marker for colonoscopy, which is known as fecal colprotectin. You probably all know about that. Because if you do other inflammatory markers like CRP or ESR, they are not necessarily elevated in colitis. They might be elevated in Crohn's disease, but not in ulcerative colitis. So in ulcerative colitis, you might have fulminant disease and your inflammatory markers may be perfectly normal. So in that case, if the patient is well, I don't do a colonoscopy or flexible sigmoidoscopy. Unless I've got a, hidden agenda, I want to, I'm doing a private practice and want to get more money, but I don't do much in the way of private practice anyway.
So if your question was about surveillance, he had already answered that at 10 years, okay? But the reason why I discuss this is because I see in my clinical practice here in Karachi, regularly patients coming who've been endoscoped, colonoscoped every year because they've got ulcerative colitis.
That's wrong.
And they are well. Even for flare-up, if you have calprotectin and you do that and it's there, it's high, then you can restart treatment or upgrade treatment. If you have any confusion about the fact that whether the patient is actually has got active disease or this is infection in our society, sometimes you can make a case for looking at the colon to see whether it's actually flare-up or not. But to do routine colonoscopies in everybody with ulcerative colitis, which is a practice in Pakistan, in a lot of centers, is really unnecessary, and that's the point of this discussion. You don't need to call back patients who are stable just to see if they've got active disease or not. Okay, that's what.
Sometimes a patient may have symptoms for long years ago, and he is diagnosed later. I mean, he diagnosed 1 or 2 years ago, but his symptoms are persisting for so many years. Then at which time you will start thinking of having surveillance?
No, it's, if he's undiagnosed with symptoms, then, because a lot of times this happens to us as well. Patients have had history of diarrhea, change in bowel habits for years, and they are labeled as irritable bowel syndrome. So the moment you diagnose the patient, you start treating them, right? The other thing is Dr. Sadniaz pointed out very rightly that all flare-ups are not due to colitis. Infectious diarrhea are equally common in these patients. They are more vulnerable to C. difficile infection, and they are more vulnerable to CMV infection as well. So routinely when we do a diagnostic flexible sigmoidoscopy, we also test for CMV. And
I think in answer to your question, what you're saying is, or asking, you could have symptoms for 10 years, you finally go to the doctor, you finally get a diagnosis. You're asking, should I survey that patient? I'm saying no, because if you've done your diagnostic colonoscopy correct, which is that you've looked at the colon, you've taken your biopsies appropriately, and then you've come out and you've found nothing to actually suggest anything there sinister, then you put them on the 10-year surveillance. Should you then have, in my practice, you have any concerns that of compliance, that's the only time I would actually then relook. A lot of the time it is actually, is your treatment regime correct for that patient? If not, look and adjust. But you don't have to go back in and have a look.
So this is the question I'm throwing to all of you. You have a 30-year-old patient who's had diarrhea for the last 10 years. Comes to you in the clinic. You ask that about diarrhea, it's like once, twice a day. And then she has good weeks where she has no problems. And then she'll suddenly have diarrhea and abdominal pain again and come back to you. And the pain gets better after defecation. No weight loss, no blood in stool, no lab issues. This has been going on for a long time. She's only 30. Should she have a colonoscopy?
Sir, if she does not have any alarming features that you said, weight loss, blood in stool, and any nocturnal
So do you all agree she doesn't need colonoscopy?
Because symptoms are persisting for so many years.
Now, how many of you have seen such patients who have had colonoscopies? Every patient that comes to my clinic with this history has already had a colonoscopy. So we are saying something else and actually doing something else. Right? Is that right?
Yes.
No, but is this practice right? No. Why would we do that? There's only one reason. Then we blame the custom for being corrupt, police for being corrupt, and we are very particular about halal and haram, Rosie. When you are clearly telling people that this should not be done and it's not indicated, and then you do it, is this halal or haram?
Sir, there is a point. Can I say? Okay. Sir, usually such patients with IBS kind of symptoms, they after all the investigation, non-invasive investigations, they are not reassured properly. Multiple times you have to reassure the patient. I mean, patients have done with all the investigations, and you just try to reassure them that you are not having any problem. But IBS people have some OCD or some anxiety and depression associated with those disease. At that time, you have to just for the reassurance of the patient, as it last resort.
Well, I'll take their point as well, but my personal answer to you is that A, we have failed in reassuring. That's our failure. Okay? And that failure is because of a bias. We do want to do endoscopy because end of the day, that's what runs our house. Okay? That's the reality. So do we have enough time to reassure patient? And 90% plus patients will be reassured if you give them time and explain to them. Nobody wants a scope up their bum. No one. Okay? Unless it's really indicated. So if you feel very strongly that the patient will benefit because they have this fear of cancer. There are patients who would come and say, Doc, mere dost ko cancer hua hai. I don't care, you have to endoscopy. That's a different case. Okay, I'm talking about patients who come in on a daily routine practice, and I see these patients. I have hardly ever seen a patient that comes to me without colonoscopy. And if I send them without colonoscopy, next time when they come to me after 2 years, they've already had one done because they went to somebody else. Okay? So the point I'm making is that you need to adhere to what you believe in and what you're being taught. If we don't, then we are hypocrites. Sorry, Vakar.
Yes, I think I just want to reiterate what Dr. Sadnias said. You need a good history and a good time with the patient. And most of the time, you would identify the ones that need colonoscopy and the ones do not need. The other important thing is, the clue in the question was that she's had those symptoms for years. Now, if it was something sinister, she would have been dead by now, right? So most of the time, the indication for colonoscopy is a recent change in bowel habits, not just change in bowel habits, right? So those are the points, and obviously there's no substitute for a good history. Secondly, you do see inflammatory bowel disease in younger patients, you do see cancer in younger patients, but then you can identify those with good history taking. Secondly, there are other parameters, non-invasive, which you can use, because as a standard, we use anti-TTG antibodies to exclude celiac disease, and we use fecal calprotectin as a non-invasive test. And fecal calprotectin is not just raised in inflammatory bowel disease, it can be raised in infectious diseases, it can be raised in cancer as well. So it's a
with anything positive. And quite often, you would end up seeing somebody doing a biopsy showing non-specific colitis, which I see in like 8 out of 10 biopsies that are done. Exactly like endoscopy, you know, when you go in and you know there is nothing, you say, oh, there's a little bit of redness, mild enteral gastritis. Mild enteral gastritis is, in my opinion, is probably normal in most people, in about 7 on 10 people. So the point of indication, I mean, you're all postgraduates, you've done your FCPS, or you're almost ready to do your FCPS gastroenterology or surgery. I think it's important to know that certain things are being taught or understood for a reason. Okay? It's very easy to endoscope everybody. Anybody who walks into a GI surgical clinic who's doing colorectal disease, scope. No time wasted. In our country, it becomes an even more important thing, because if you know, it's a private system, whether we charge a lot or whether we charge less, it's still significant amount of money that the patient ends up paying. So we need to really ask ourselves. Over 55, I would not question you. If you sit down with somebody with family history or without family history, you do a screening colonoscopy, I don't have a problem, but then you have to understand why you're doing the screening colonoscopy. And are you good enough to do a screening colonoscopy? And is the bowel prep good enough? All that. What bowel prep do we use? Okay, you use PEG? Okay. Aap bhi? Okay. Okay. We use phosphate base, so we're still using that. I find the patient doesn't have to drink a lot of water, so acceptance is a little better. Prep, by and large, we'll see. I think of the 20-25 cases we do, I think about 80% have good bowel prep, but that's also because patients don't understand. This is a bad time. I was telling Paul, this is the seeds time, so we have tarboos, melons, all kind of melons, and guava. And guava seeds are especially created for the scope. It will travel all the way and get stuck at the suction, and it works like a valve. So you can keep cleaning, it disappears and comes back. And so, you know, I think it's important for them to adhere to the colonoscopic prep. We'll share that with you in the due course. So colon prep, you have PEG, or you can use phosphate base. I usually have 24 hours of clear fluids. Okay, and if we are doing it under sedation, they don't have to be NPO. Okay, and along with that, we use 2 solutions, phosphate-based solutions, one day, 6 hours apart, depending on when we are doing it in the morning or in the evening. And the bowel prep experience has been okay. I mean, it's not bad. I think it mostly depends on patients. Those who are constipated, very badly constipated, then you have to be prepared. And obviously ask the patient before you start colonoscopy whether they are having clear watery stools or not liquid stools, because they can't differentiate between watery and liquid. Liquid can be brown and it can create lots of problems, especially in the seed seasons. So we've covered the prep. Sedation, by and large, the idea is that you use less and less sedation. We have this discussion every time in the course that when I'm doing female patients here, because of our cultural issues, I prefer them to be slightly more sedated, so they have good amnesia effect, and they don't feel any embarrassment. If the patient requests propofol-based anesthesia, I give them that option in women, young ladies, and all children. But preferably, I think if you're not very experienced, any anesthesia-based colonoscopy is more dangerous than sedation because you lose the patient's pain threshold as well as response to pain, which actually helps you to stop the colonoscopy or to understand that you're creating a loop or making life difficult for the patient. So we've covered indication, and what we want to do now is look at, in between we'll cover up a couple of other things. In the course, we'll show you how the scope is washed. It's very important for those who have got smaller units and less experienced techs to actually understand this, and occasionally just go and ask them how they're doing. Also know how much time it takes to clean, so that if you've got a list of 6 colons and you've got a single colonoscope, then you should know that it will take you, how long will it take you? Should it take you? 1 hour? If you take half an hour in colonoscopy, half hour cleaning, it should take you 1 hour before you are going. So after you're done with colonoscopy, at least half an hour before your next case. So if your technician is bringing, well, 20 minutes minimum. But if he's bringing it quicker, or you are forcing him to bring it quicker, you're not doing justice. Okay? So don't try and do more. Do it effectively. Do it the way we should be in our circumstances. They've gone to a different level in terms of monitoring, in terms of scope storage, and in terms of scope cleaning. We are still mostly manual cleaning. So manual cleaning, in my opinion, is fine. Okay, there is more automation in the Western world. We have more labor force here. Manpower is easier to get, and so we use that more in our part of the world. There is, in my opinion, there is nothing wrong as long as it's done properly. That's how they were 25, 30, 35 years ago. Yeah.
I think if you look at what our system is, as Saad says, manual cleaning is what you do. Manual cleaning is the most important part of looking after a scope. The part that is not done very well is the disinfection. So what you've got is that you use glutaraldehyde still, and that carries all its complications. Now we don't. So the part where we let ourselves down is the manual cleaning. So people who actually look after scopes in the UK, even though they're supposed to brush through a scope minimum of 3 times, clean the scope, make sure everything is really clean and thorough, then put it into the processor, which takes 45 minutes for the scope to go through. Then it'll fail in the last cycle, which is 2 minutes to go. Then it has to come out and then be redone again. But if they'd have manually cleaned the scopes properly and appropriately right at the beginning, there'll be less failures. So manual cleaning is very important, and that's what you've got to hammer home to people. The other most important thing is that all parts, because you use the glutaraldehyde base, needs to be covered in glutaraldehyde, sucked into the scope, make sure that everything is soaked within the scope. The thing that I'd like to ask you is, what do you put on a consent form? So when you consent a patient, what do you actually not consent for, because you're consenting for a colonoscopy, but what do you actually say to a patient are the risks of having this procedure? So if I was to ask you guys, what are the risks you would mention to a patient, to every patient you consent, what would they be?
First of all, they might have preparation. If you are doing a procedure like polypectomy, they can bleed. Also the side effect of the anesthesia or any kind of sedation, they can get the complications. Infections.
So you're saying perforation, bleeding, and the sedation that you use, okay? Anything else? Infection. Over here, that's appropriate. If somebody gets an infection from a scope in the UK, it's litigation. Okay. Electrolyte imbalance, that's very... Okay, so a complication of the prep. Okay, that's fine. He's already included. Is that it? How about incomplete procedure? How many procedures would be failed in an average, do you think? What is the average to fail on a colonoscopy? 20%, one in five. So I quote you 97%, so I'm a liar. No. 1 in 20, so 5% is a incomplete, so you're not failure to get round. That's the national figure. Anything else you actually would consent for?
Any alternative test?
Alternate test?
Yeah.
Yeah, well, we're very poor at offering alternate tests because that offers money to somebody else. What about failure of prep? So, again, prep is a thing we don't mention to patients. Prep, first of all, we're ruling out pathology. If the prep isn't good enough, you've got to be honest. So that's one. If we actually look at these figures, and we actually now add the two together, I should only complete 9 out of 10 procedures. So you shouldn't hear a quote of 97, you shouldn't hear a quote of 92, 93, but you do. That's because we're talking about the average of, it's the bad bowel preps that we have and the strictures that we have that we don't complete. They're the ones that we struggle with most. But the biggest thing is, if I actually struggle and I don't complete, I'm not too big then to turn around and then say, ask a colleague of mine to, if he's available, or then to refer him to them and be honest on the report. Failed today, and I might not be having a good day. That's the big, most important thing. Admit when you're not having a good day. But when you don't succeed, don't be too big to actually say, can somebody else have a look at this for me?
I think that's very important. One of the reasons I struggle is when I've got something to do at the time of the day where I'm absolutely done, and somebody just says, "Oh, you know what? Can you just do this, please?" And you know your mood is not at all to do that. You're doing it with no keenness at all, and you just want to do the procedure. That's where I'm caught. Okay, very often. So that is something that happens to all of us. So I think it's very important to be honest. Okay, I think honesty in all aspects of life is must. So is a must. So if we can't do something, then we can always find someone who might be able to do it. And if there is no one else you think you can, who's better than you or who's more experienced than you, then fine, then you have other options to do. And you should always come out clean. And I tell you honestly, every time you're all upcoming future surgeons and gastroenterologists, every time you'll be honest with your patient, you'll be surprised how respectful they are, even in your failure. A lot of patients come and you know, they're so thankful for someone who's referred a patient to me from elsewhere for a procedure. And when we've done that procedure, they're more thankful to the person who sent the patient to me than actually to me. And what we don't realize is that the patient doesn't realize. Patient doesn't go back thinking, oh, he's useless. He goes back thinking, and that guy was really good, he was so honest, thanks to him he referred me to you. You know, sometimes you feel, man, you've done the procedure, and it was a difficult procedure, but they're not really thankful to you. They're thankful. So we have to understand, and at the end of the day, you have to be honest, you have to be answerable to him. Bowel prep is an issue. When you're talking about 98, 99, 97%, you are obviously taking out things that stop anybody going further, whether it's because it's a tight stricture and you can't negotiate, or whether it's because the bowel prep is so bad that you put the scope and you come out. There is no point. Okay, you can fool yourself. The only exception, Paul, in where I persevere or persist with bowel prep, bad bowel prep, is where I want to just see the ileocecal valve in a young person with possible TB. So that is the aim of colonoscopy. CT scan has shown there is a problem. The bowel prep isn't good. I'll still try as much as I can to reach the cecum, because once I've reached the ileocecal valve, I can wash it and look at it, and if it's normal and got into terminal ileum, then at least I can say that that's clear, that it's unlikely to be, or the CT scan report is not, is not correct, or whatever they've seen is not TB. That's something that
I absolutely agree on that. And to actually get you an excellent image in your cecum, there is things that you can do. So washing is one of them. But actually, what do you actually use in your wash? So people may use water, but stool is very thick and tenacious and it sticks. So what I use in my practice is I get a phosphate enema, I mix it with the same volume of water, squirt it down the scope, leave it where it is for a minute, and then aspirate. And then you'll find that the image then becomes clear. It's slightly red, so I don't actually mention the erythema, because that is how phosphate enema works. It irritates. So if you see a slight redness, that's because of the enema, not because. And we have got to be mindful, and Saad has mentioned it before about the mild gastritis. There are things that we choose to be on the report and not on the report for purposes.
Okay, so Sajda, I'm done. We'll just